Okay. Yeah, live, sir.
Yeah, good evening, everyone. I am Mayank Gupta. On behalf of Pfizer, warm welcome to all my three eminent speakers and participants. As we know, following Pfizer long tradition in promoting science and providing a platform for interactive and insightful discussion, it gives me great pleasure to invite you to attend this continuous medical education meeting. So today's meeting agenda is we will cover about growth disorder. First topic will be evolution of short stature. Next, case-based approach in SGA children. Then case-based approach in Turner syndrome. After that, Q&A session. So our first moderator, we will call Dr. Richa Arora. So Dr. Richa Arora has done MBBS, MD and DNB. Then SC in diabetic and endocrinology from UK. Then she did diploma endocrinology from USW. Then APIS fellowship also. She is an executive board member of North Delhi IP. She was a organizing secretary of Indocon from 2018 to 2021. She is a consultant pediatric endocrinologist in Fortis Hospital, Shalimar Bagh, Saroj Hospital, Jaipur Golden Hospital, Rohini, Rajiv Gandhi Cancer Institute Hospital, Rohini, Delhi. Now, without wasting more time, I would like to invite Dr. Richa ma'am, please, and take a session.
Thank you. At the outset, I would like to thank the Pfizer for taking this initiative of basically imparting the knowledge of growth disorders. I welcome my co-speakers, Dr. Divya and Dr. Kiran. Welcome. So as discussed, our topics we will be discussing three. First, I will be discussing the overview of evaluation of short stature, and then we will have a case-based discussion. I request all the participants, they can start, they can put their questions side by side in the Q&A corner, and we will take the questions at the end. And in between, if during the session also, we can discuss them. So first, I would like to discuss what is short stature. So at the outset, I would like to say that in a cases of in pediatric endocrinology, most of the time our patients do not come with complaints. It's during the routine clinical evaluation, we see that they have some issues and then we address them. So, but for regarding short stature, many a times the parents visit us with the complaints of short stature. My slides are not moving. Yeah. So whenever we talk about short stature, any child coming to our OPD with complaints like my parent says, my child is not growing well, my child is shortest in the class, my child is growth is not as per to the peers, his clothes are not changing every year, the shoe size is not changing. These are the basic small complaints sometimes the parents come with, or during the routine examination when we check the weight and the height of the child, we feel that the child is shorter or falling back from according to his age group. So broadly, the short stature could be a physiological short stature or a pathological short stature. When we talk about physiological short stature, it could be either a familial short stature in which the parents are short and the child is destined to be short, or it could be a constitutional short stature in which the parents are not short, but they are late boomers, they grow late. So we don't need to, we need to keep these kids under close follow-up and do not require extensive evaluation and treatment. On the other, if we are, we will see how we will be going through this this algorithm again and again during the presentation so that we can discuss, we can understand how to go about whenever we encounter a case. When we talk about pathological short stature, it could be a problem in the core growth plate, or it could be some secondary causes. Core growth plate problems, it could be epiphyseal issues, or it could be metaphyseal dysplasias. Or when we don't see any issues, then either there could be nutritional factors like chronic diseases, chronic malabsorption, or it could be chronic renal failure or chronic liver disease, child having chronic infections, recurrent infections, or it could be endocrine causes like hypothyroidism, it could be growth hormone deficiency, Cushing syndrome. So whenever we see a case, we have 3 questions to ask. First, we have to confirm that it is a short stature, because the parents might be feeling the child is short, but actually when we measure it and plot it on a growth chart, we find that it is not short. So first we confirm it is a short stature. Then is it normal or it is a part of a disease? And if it is a disease, what is the cause? So whenever we are evaluating any child with short stature, it's like walking on a tightrope, because 2/3 of the causes are physiological and 1/3 are pathological. We don't want to over investigate every child coming with short stature, but at the same time, we don't want to miss an important cases, because their action during which they can be investigated is very small time. So we don't want to lose an essential time. So before labeling a child to be a short stature, first and foremost is measurement of the height. Accurate measurement is very important. For less than 2 years, we take a supine length with an infantometer. And for the older children, we use a stadiometer. These are the 2 pictorial photos of the instruments that we use, infantometer and stadiometer. So we have to see that whenever we are measuring the weight, height of a child, it has to be, shoes and head accessories have to be removed. Whenever the child is standing, heel, buttocks, back, and occiput all should be in the straight line, and eye should be at the level of patient eye when we are seeing the on a stadiometer. And when we are talking about taking a supine length, the horizontal board with a fixed plate and movable foot plate can be used. 2 people are required, one to hold the head and second to keep the knees straight and hold the feet against the foot plate. So measurement is very important, and again and again taken at the same place or the same observer. The chances of inter-observer differences are less. So once we have taken a height, we plot it on a growth chart. So this is a growth chart. See, like this is a child whose height is much less than the 3rd percentile. So this will come in the classification of short stature. Or it could be a child who is just below the 3rd percentile, but he is growing slowly, or in other words, his growth velocity is less than the expected for his age. And the third could be a child, when we are seeing only at this point, we might feel that the child is not short. But if we see the child is not growing at all for last 1.5 years or 2 years, or in other words, there is falling off of the percentile levels. The child was on the 95th percentile and now he has reached the 10th percentile level. So this also indicates the importance of close monitoring, because if we have seen the child only here, we might feel that the child is okay. But if we know the continuous readings, then we can understand that the child is not growing and they are falling off the percentile levels. So by definition, any child whose height is much below the 3rd percentile, growth velocity is less than the expected for the age, child is not growing at all, child falling off the 2 percentile levels in the prepubertal age group. So these comes the definition of short stature. These are the categories that we include in short stature. Now, once we are confirmed that we are dealing with the child of short stature, our next question is whether it is a physiological short stature or a pathological short stature. So the next question is, what is the most important investigation once the child is diagnosed with short stature? The answer to this question is a growth chart. The growth chart is the most important investigation before going for any invasive investigations. So when we look at the growth chart, we get to see 3 important parameters. First is the weight and the height percentile, which gives us the absolute status of the child at that point according to the population in which the child is. Second is the parental expectation, in which we calculate the mid-parental height, plot it at the 18th year, and see the familial effect of the child, because the child may be short maybe short according to the population in which he is growing, but according to the family, the child may be normal. So we will be unnecessarily investigating a child who is normal. So whenever we plot a mid-parental height, we are negating that effect. The third and most important is weightage and heightage. We see that we will see a few examples also how this is important. Heightage is the age at which the present height becomes the 50th percentile. Weightage is the age at which the present weight becomes the 50th percentile. So this helps us to know that which parameter is more affected. If the weight is the first parameter to be affected and height appears to be secondarily affected, we are dealing with nutritional factors. And if the height is the first parameter to be affected and weight appears to be secondarily affected, we are dealing with endocrinal factors. So, first point we have seen already. The second is the mid-parental height. How do we calculate the mid-parental height? We take the father's height, we take the mother's height. For the boys, we take the formula of father's height plus mother's height plus 13 divided by 2. For girls, it's father's height plus mother's height minus 13 divided by 2. And then we plot it at the 90th, at the 18 years of age. So we will see this few cases according to it and how we apply these points. Like we have a 4-year-old girl whose height is 92 centimeter and weight is 15 kg. So we see that the weight is at 50th percentile while height is just at the 3rd percentile. So let's we saw that the mid-parental height, the second important parameter. So that is the father's height is 160 and mother's is 147. So we have a mid-parental height of 147 centimeter. So what we see in this is a child who is very short. If it's short on the 3rd percentile according to the population in which the child is. But when we see the parental effect, the child is growing fine according to the family. So for heightage and weightage, the heightage is 2.7 years and weightage is 4 years. So we have this child is it a abnormal child? Celiac growth hormone should we know? No, it's a common familial short stature because the child is growing continuously. So importance for such children is close monitoring. We should be checking the growth velocity over the years, and we should be seeing there's no need to get extensive investigation in such a child. See another child. We have a 36-month-old girl. Birth weight is 4.1 kg and presented with growth failure. So this child was continuously being followed up by the pediatricians, and what they saw was at birth the child was at 95th percentile level, and now over the time after 3 years the child has reached the 3rd percentile level. So as according to the definition, there is a falling of the percentile levels. So the child is they refer the child. But what we see in this child is, let us see the other parameters also that are equally important, because just showing and going for the extensive investigations, before going for the investigations, let's see all the 3 important parameters. So what we see is the child's mid-parental height is 150 centimeter. So it shows that the parameters at height at birth is depending upon the weight of the child, and what we saw was the child's birth weight was 4.1 kg. The child was born from a diabetic mother, so the length at birth was dependent on those factors, but finally the child will be taller also. As in an SGA child, the child is underweight, so child is short also. So there is a normal catch-up growth for SGA children. Similarly, the LGA kids will have a normal catch-down growth. So this patient is not a case of any acidosis or celiac or hypothyroidism. It's a normal catch-down growth. This we came to know when we plotted this on a growth chart, and which plotted the mid-parental height. Without knowing the mid-parental height and extensively investigating this child will not be right. So again, close follow-up, see the growth velocity and see how the child is progressing further. And most probably if the child is not further falling in the percentile level and continues to grow in his parental percentile level, he does not require extensive investigation and further any treatment. So we have reached the second part of our algorithm in which we are discussing the physiological causes. Now coming the For physiological, if we talk about familial and constitutional, the second important investigation is a bone age. For the bone age, which X-ray do we take? We take X-ray left hand, wrist to tip of the finger. We can see the with Creutzfeldt method or Tanner-Whitehouse method, and maturity is from proximal to distal, while fusion of the bone is from distal to proximal. So on the basis of the growth chart, on the basis of the pubertal status and the bone age, we can differentiate between physiological and pathological short stature. So if we talk about constitutional delay, familial short stature, the child is short, parents are short, child is destined to be short. In that, bone age and chronological age correlate. Their growth velocity is normal. Parents are short, maybe grandparents and siblings are also short. They are normal physical examination, there is normal development. And when we have a constitutional delay, they are late growers. There is usually a history of constitutional delay in the family. Their bone age is retarded as compared to the chronological age, but usually within 2 years. So they are late boomers, but important point to be noted here, they can be pathological also. So if the bone age is not delayed beyond 2 years, we take it as a constitutional and keep these kids under close follow-up. So this is a routine chart that we see in a familial short stature. They are short, continues to grow, and then finally, but in the constitutional short stature, they are short, continues to grow, and then finally, but their height is normal. So delay of 2 years or more in bone age from chronological age is clearly abnormal. A short child with delayed bone age carries a better prognosis for attainment of ultimate height than a short child whose bone age is consistent with the chronological age. So once we have ruled out that no, the child is short, the bone age is much delayed, or there is some other reason, then we look for this side of the algorithm. So whenever we are suspecting any pathological cause, we have to first identify any genetic syndromes. There could be few clinical pointers like polyuria, which suggests of renal tubular acidosis, or diabetes insipidus, or it could be anemia like chronic renal failure or celiac disease. It could be disproportionate short stature like skeletal dysplasias, or it could be Turner syndrome. So this is again a child presented with short stature, milestones delayed, intelligence normal, short limbs, chest wall deformities. There is metaphyseal flaring. So what we see, this is an abnormal upper segment, lower segment ratio. So this was a case of achondroplasia. Again, this is a child, we will be discussing this in further details. This is a child, parents are not short, but they have few clinical pointers. These are few clinical pointers. Dr. Divya will be discussing in detail. This is a case of a Turner syndrome. The child had webbed neck, low hairline, lymphedema, associated kidney abnormalities, heart defects. So a detailed history and physical examination will also help us point towards the diagnosis where we want to go. So again, a child, 6-year-old child could not walk very well, legs are very thin, has short stature, poor weight, resistant rickets. So this is had investigations. Once we have seen these clinical parameters, we investigate on the lines of renal tubular acidosis, and we saw there is hypokalemia. ABG showed mild metabolic acidosis. Ultrasound abdomen shows nephrocalcinosis. So this is a case of a renal tubular acidosis. Another child of a 6-year-old child with global developmental delay, short stature, typical facies. So this is a case of a hypothyroidism. So till that cases in which on the basis of history and physical examination, we have clinical clues. And on the basis of the clinical clues, we were able to take our investigation on those lines and treat them accordingly. But now there could be many cases in which there are no clinical clues, there are no pathological markers, there are no syndromic markers. How to go forward with such cases? Let's see another case. Is a 5-year-old girl with a height of 95 centimeter and weight of 11 kg. What we see is the parents are also at 3rd percentile level. So is it again a familial short stature or there is something else? Let's see the 3rd parameter, that is the weight percentile and the height percentile. What we see is the height age is 3 years, but weight age is 2 years. So it is important to see that the weight is very affected as compared to the and height appears to be secondarily affected. So we need to see nutritional causes in this case. So investigations like celiac, to rule out celiac disease, any chronic disease. So this question came out to be a case of celiac disease. So again, a child, 5-year-old child, height is 86 centimeter, weight is 15 kg. Parents had a percentile level of around 25th percentile. So let's again look at the weightage and the heightage. What we see is the child on examination also had micropenis, immature facies, undescended testis, and had delayed bone age. So after excluding other causes, there is no role of getting a basal growth hormone. We have to go for a GH stimulation in such a case. And in this case, what we see is heightage is more affected than the weightage. So we look for endocrinal causes in such cases. So just to recapitulate, if we are having a child whose height is more than 3rd percentile, it's not a case of short stature, only close follow-up. 1st to 3rd percentile, look for the growth velocity. And if the child has less than 1st percentile, we look for the first clinical parameters, and then we take away investigations on those lines. If the weightage is more affected than the heightage, we look for chronic diseases. It could be celiac, malabsorption. Or if the heightage is more affected than the weightage, we look for causes like growth hormone deficiency, hypothyroidism, Cushing's. So growth chart is a fundamental tool to diagnose any child. Weight is an important criteria to clinch the diagnosis. Constitutional short stature is usually a retrospective diagnosis. So such children should be on close follow-up, and stepwise evaluation is the key to go forward in such cases. Thank you. So once after the evaluation, so now I give to Dr. Kiran. Dr. Kiran will be discussing case-based approach in SGA children. She is MBBS, MD, and fellowship in pediatric endocrinology. She is in Pune. She is presently consultant pediatrics endocrinologist at Surya Hospital, Jaipur. Welcome, Dr. Kiran, and over to you.
Thank you very much, ma'am. Are my slides visible, ma'am?
Yeah, they are. Just make slideshow. It's not.
Yeah. Okay. Thank you very much, ma'am, for the kind introduction. And at the outset, I would like to thank Pfizer for this opportunity. Today, I will be talking about small for gestational age children in regard to their growth and endocrine concerns in a case-based approach. These are my disclaimers. So the table of content of today's topic will be, first of all, I'll talk about definition and epidemiology of small for gestational age children. I'll be referring to them as SGAs in short. Etiology of SGA, cases to understand SGAs, consequences of SGAs, diagnosis and management of SGA children, a little bit about the case study, and then I'll take you through the take-home messages. Talking about the definition and epidemiology of SGA. An SGA is defined as a neonate whose weight and or crown to heel length at birth is less than 2 SD below the mean for the infant's gestational age. This is also equivalent to 10th percentile. Some of you will say that that 10th percentile would correspond to -3 SDs. Yes, there has been variations, but for all practical purposes, the birth weight length below the 10th centile will be classified as an SGA for that appropriate reference population. SGA can be classified as those who are low for birth weight, SGAW, those who are low for birth length, SGAL, or SGA with low birth weight as well as length, SGAW plus L. So whenever the term SGA comes into picture, the next term which pops up in our mind is whether it is an IUGR. So to clarify that point, I would like to take you through this table where I will, so that we are able to differentiate between the two. An IUGR, as the name suggests, is intrauterine growth retardation. These babies will always appear malnourished. The measurement is by the help of fundus to pubic bone measurement using an USG or Doppler. There will be change in the growth of these babies over the time. The growth rate in the uterus is always slower than the normal counterparts. The birth weight of an IUGR baby sometimes may be lower than normal, but will not be the case always. IUGR mostly is because of a pathological condition, whereas small for gestational age is a fetus who is small for that gestational age. They appear small, but they are mostly not malnourished. The diagnosis is measurement of the fundus to pubic bone when they are intrauterine. And once they are born, it is a one-time measurement that will fall below the statistical value. The growth rate in uterus for an SGA baby can be normal or slower than the normal. Birth weight or length or head circumference will be less than the normal in an SGA baby. SGAs may be because of a pathological condition, but not always. It may not be the case always. So all IUGR babies are not SGAs and vice versa. To put it in a graphical representation, here we can see that this graph under the white curve is the normal AGA babies. So this dashed line represents SGAs, but not SGAs and IUGRs. They are fulfilling both the criteria for IUGR as well as SGAs. The line below this is dashed line represents an IUGR but not an SGA. Sorry, SGA but not IUGR, because he is below the birth length or weight is below the -2 ST. Similarly, the small dotted line represents an IUGR but not an SGA because it is not fulfilling the definition of an SGA child. So why are we talking about SGAs? We are talking about it because India has the world's largest number of SGA births, 12.8 million as per the 2010 data. So to simplify these figures, I will put it in a way that every year 50,000 new babies are born who result in short adults, the cause being them and born as an SGA child. The prevalence of SGA birth is approximately double the prevalence of low birth weight babies. But probably we have taken care of our low birth weight babies, reduce the mortalities, but now it is high time that we address the SGA babies, which are approximately double in prevalence and will further reduce the morbidity of these children. Furthermore, the national health programs, maternal neonatal care programs must be taking care of this aspect. So as I mentioned, the prevalence of SGA in India is very high, and this is the high time that we must start taking care of our SGA babies as we had taken care of the low birth weights or extremely low birth weights. So what are the etiologies of SGAs? They could be maternal factors, placental abnormalities, or fetal factors. Maternal factors like birth weight of the mother, parity, age, short and long interval between the birth, previous stillbirths, socioeconomic status, maternal education, smoking, drug uses, alcohols. Definitely gestational weight gain during the pregnancy, number of pregnancies in terms of parity, anemia and epilepsy. These all maternal factors will contribute in making an SGA baby. Apart from that, there could be placental abnormalities like preeclampsia and others. Fetal factors like multiple genetic syndromes. So we must be addressing knowing the etiology so that we can address the cause of an SGA and thus further reducing the number of SGAs born. So why is SGA a concern? They have short-term consequences and long-term consequences. I'll just enumerate the short-term consequences and go in detail about the long-term consequences. So short-term consequences of being born in SGA could be an hypoglycemia. Around 1 in 3 baby have an hypoglycemia after birth. They have thermoregulation difficulties. They have hematological difficulties like excess red cell production, decreased platelets. Thrombocytopenia is found in more than 50% of SGA infants. They have difficulty to adapt after delivery. These are the situations which are definitely better taken care by our neonatologist friends. So I'll not be going into detail, but yes, they have short-term consequences. Coming on to the long-term consequences, they can be growth-related or system-related. Growth-related can be short stature per se, or adiposities, or decreased bone mineral density. Systemic related like cardiovascular complications, obstructive pulmonary diseases, type 2 diabetes mellitus, renal insufficiency, or impaired reproductive functions in their later years. Talking in detail about the endocrine consequences, an SGA baby have an growth hormone insensitivity or resistance, resulting in growth hormone IGF-1 axis with poor response. They may have a poor hypothalamic pituitary adrenal axis. When talking about puberty, they may have the age at onset may be normal, but the duration of the puberty is decreased, resulting in early menarche. Most of the SG babies who show good catch-up may result in early adrenarche. At the same time, the pubertal growth spurt is relatively decreased, thus resulting in short adult height. Bone age is a poor predictor of adult height in SGA babies because the bone age algorithms which we are using are derived from the normal children. Problems like hypospadiasis and cryptorchidism are more in SGAs. They have been shown to have marginally increased frequency of polycystic ovarian syndrome in later years. They do have decreased bone mineral density. So I will take you through a couple of cases where we would be emphasizing the endocrine consequences. Coming to case 1, he is Master A, a 6-year boy, coming to us with concerns of short stature since beginning. When we ask when was it when the parents first realized, they are saying that since his birth, he has not been gaining weight and height appropriately. He's born to a primary mother with no significant antenatal history, but he was a late preterm 37-weeker with a birth weight of 1.4 kg. Normal delivery, cried immediately after birth. So as we had discussed the definition of SGA, he is falling into the category of SGA. History of feeding tells that child was having feeding difficulties and was stopped for breastfeeding and was on top feeds mostly. So this is the pictorial representation of the child. So on clinical examination, he was grossly short, thin-built, dysmorphic, broad forehead with a small triangular face, a small narrow chin, limbs have little limb length discrepancy. Lower limb discrepancy was 0.5 centimeter, more than 0.5 centimeter. There was clinodactyly, which is the curving of the fifth finger. The abdomen was protuberant. The genitals were normal, and there was no organomegaly as such. So, as evidently seen, this seems to be some kind of syndrome. Let's go ahead with it. When we went through the growth data of the child, the auxology comes out as at 6 years of age, the height is corresponding to 2.6 years, weight age is corresponding to 2.6 years, bone age is around 5 years. He is definitely short. As we can see here on the growth chart, he is definitely short. And from the previous data, the growth velocity was 4 centimeters per year. So with the clinical examination and the auxology, we made a diagnosis of a syndromic short stature, probably Russell-Silver syndrome. After confirmation of the diagnosis, the child was started on the growth hormone and the growth velocity increased to double. So what could be the possible other differentials? In this particular case, the child is having asymmetry, his failure to thrive, he's short. So a probable diagnosis of Russell-Silver syndrome was made. What is a Russell-Silver syndrome? So Russell-Silver syndrome is a syndromic short stature. It is basically a clinical diagnosis which can be understood by the Nash-Harbinson clinical scoring system, which says among these 6 criteria, if 4 are fulfilled, child can be classified as RSS. I'll take you through these criteria. SGA by birth weight and or birth length, postnatal growth failure, relative macrocephaly at birth, protuberant forehead, body asymmetry such as lower limb length discrepancy of more than equal to 0.5 centimeter, arm asymmetry or lower limb discrepancy of less than 0.5 centimeter with at least 2 other asymmetrical body parts sparing face, history of feeding difficulties and persistently lower BMI. So in this particular case, the criteria highlighted in the blue were fulfilled and a clinical diagnosis of RSS was made. So once I have made a diagnosis of Russell-Silver syndrome, should I go for growth hormone testing? The answer is no, because most of these children have the production is okay. It is the growth hormone resistance. Definitely the secondary causes must be ruled out, and they were ruled out. What are the other conditions where we don't need growth hormone testing? SGA babies, Russell-Silver syndrome, Prader-Willi syndrome, Turner's or Noonan's, and short stature with pituitary mass post-surgery. So the meanwhile, after with our clinical diagnosis, we started the treatment. We started symptomatic treatment along with our multidisciplinary team. The child was started on high protein, high calorie rich diet. Some appetite stimulants were given. The role is plus minus. Growth hormone therapy is started at 50 mg per kg per day. Meanwhile, the genetic reports come back, and that confirms the diagnosis of Russell-Silver syndrome. The pictures are not of the patient per se, but they are pictorial representations. So why is the monitoring in children born SGA is important? It is important because the case which we have just seen, the child was 6 years. He could have been diagnosed earlier and the better results could have been got. So early evaluation is very important. And for that, measurement of length, weight, and head circumference every 3 months for the first 3 years, for the first year, and then every 6 months must be done so as to make the diagnosis on time. Multiple data has come up which suggests the earlier we treat, the better are the results with the same amount and duration and cost of the therapy. So once we have taken these measurements, how do we interpret them? To interpret the measurements, we should put them on the appropriate charts. So which charts to use? So for the children who were born preterm, previously modified Penton charts are being used, and more and more data is coming in favor of Intergrowth 21 charts, though our neonatal care units are still mostly using Pantons. But Intergrowth 21 may be a little better when talking about SGA children's per se. One point against it is that, yes, it will over-predict the child being SGA, but then to overcome, firstly, we must monitor the child for his or her own growth centiles. Whenever the crossing of 2 or more centiles is happening, it is a matter of concern, because apart from picking up the failure to growth, we are also concerned about overt catch-up. So after 2 years or in preterm babies, with correction for the gestational age in the first 2 years of life, IAP WHO growth charts must be used. Again, crossing of centiles or not catching up as per the parallel to the centile lines will be a matter of concern. This is IAP WHO growth chart for girls, which is 0 to 5 years, which would be the appropriate growth charts while taking care of these SGA babies. So while we are taking care of these babies on these growth charts, what to look for? Children born SGAs have a higher risk for short stature than those born AGAs. Yes, 90% of them will catch up during the first 2 years of life. Those who don't catch up in the first 2 years are unlikely to catch up. So 10% of these will result in short adults. Talking about the preterm SGAs, yes, they may take a little longer. For them, it is like we wait till 4 years, but beyond that, it is better to intervene. So to put it in tabular form, for a term SGA, the catch-up in terms of head circumference will be by 1 year, weight in about 1.5, and height by 2 years of age. For a preterm and extremely preterm, weight will catch up by 2 to 3 years of life, and height should catch up by 4 years. If it is not happening, even in Indian scenarios, yes, this is the high time that the child must be evaluated further for the failure to catch up. So the important message from this particular case is we must ensure appropriate anthropometric measurement along with weight, length, and head circumference also at birth, regular growth chart monitoring of weight and height and a detailed clinical examination to rule out any syndromic short stature. This will enable early identification of SGA babies who would require growth treatment and will result in optimal outcome. So, suppose the child was born SGA, we have been monitoring the child and he is showing a good catch-up growth. What now? Should we just discharge them from the OPD? The answer is no, because those who have shown good catch-up growth, they would still need us. So as to prevent excessive weight gain, they will need further evaluation. Why so? To understand that, let's go through another case. So he was an SGA baby Y, who is now 9 years, who had shown catch-up growth on our follow-up OPDs. So, but the present concerns are the child is showing excessive weight gain since 4 to 5 years. There's blackness around the neck and disturbed sleep for about a year. No other significant history in the child. Birth history suggested the child was born at term, but the birth weight was 2 kgs. And the mother is little overweight. So as we see this child on this particular, on the growth chart, we can see here, the child has grown very good in terms of height. The child has shown catch up and is now falling into the mid-parental height expectations. But as far as weight is concerned, after 2 to 3 years of life, the child is showing excessive weight gain. So much so that the BMI is now 37.94, suggestive of morbid obesity. So the child is heavy and not tall with a BMI of 34. So this is definitely an endocrine problem here. And what is it? Let's discuss this. The blackness in the nape of neck and axilla is acanthosis. The BP is on higher side. SMR for a 9-year-old, A3, P3, B2, B2, and along with lipomestia, it is little on higher side. Truncal obesity is also there. So what are we dealing with? Basically, we are dealing with the early phase of metabolic syndrome, if I may say so. And why is it happening? To understand that, let's go back to Barker's hypothesis or thrifty phenotype, which basically tells us when a fetus is exposed to a stressful environment in utero, the programming happens such that the initial insulin resistance or insulin insensitivity followed by insulin resistance develops in the newborn period, and the programming of happens in such a way the child is predisposed for the development of metabolic syndrome in later years, as is happening in our case. There is a concept of early adiposity rebound. So many a times it had been seen in clinical practice that there's a general perception of the parents that, okay, even if the BMI is on a higher side, as the child grows, it will come down. It doesn't happen like that. Any child who have an increase in BMI percentile in less than 5 years of age is a red flag for early adiposity rebound. So the prevention of obesity, which is another epidemic right now, is in the early years itself. So what is metabolic syndrome I'm referring to again and again? This is basically the IDF 2018 has defined it for 10 to 16 years, though the definition does not apply to those below 10 years of age. But for all practical purposes, those around that age, if showing any metabolic derangement with risk factors, they must be considered to be at risk for development of metabolic syndrome. To define it, central obesity, waist circumference for 90th centile. This is the IDF criteria. For the Indian scenarios, waist circumference more than 75th centile. In comparison to the Indian population is taken as central obesity. Hypertension with systolic blood pressure of more than 130 and diastolic of more than 85. Hypertriglyceridemia with TGs more than 150 milligram per dl. HDL less than 40. Fasting blood sugars of more than or equal to 100. If any of 2 of these criteria are fulfilled, then yes, the child is at risk for development of metabolic syndrome, as in our case. Apart from, but definitely it is always in diagnosis of exclusion with the history and examination, we have ruled out the child is not fitting into Prader-Willi syndrome, monogenic obesity, syndromic obesity, or any other cause of endocrine obesity like hypercortisolism, hypothyroidism, or leptin deficiency. As the methylation study turns out normal, we make a diagnosis that this is an SGA baby who has caught up rapidly and is now resulting into an obese child. So what is the management? Lifestyle changes, dietary advice, change in the sedentary lifestyle, promoting physical activity is the primary thing right from the beginning. Avoiding dense calorie-rich feeds or rapid catch-up growth, forcing them, comparing them to the other children of their age, not giving the time to catch up appropriately are to be avoided. In this particular case, statins and blood pressures may be needed if the child does not show improvement in a 3 to 6 months of time. This was one of the consequences. What are the other consequences of SGA? Or the prevention of obesity has to be done right from the beginning, right from the fetus, so that we can prevent the development of obese individuals. What are the other SGA concerns? They have poor cognitions, they have behavioral issues, poor quality of life, appetite dysregulations, blood pressure issues, insulin sensitivity, short stature, bone maturation problems, bone mineral density is low. They have early adrenarche. Some may have early menarche also. There could be gonadal dysfunctions, pubertal development in kidney and heart. So basically, a child who is born SGA, almost each and every aspect of that child, along with height, is affected. So because we are now aware of the endocrine consequences, we must be managing an SGA child. We should not leave them as it is. We should not say to the parents that bada ho jayega, gradually ho jayega. No, as I mentioned, if that child is not catching up, even if a preterm SGA is not catching up by 4 years, yes, it is the time for the management. And what is the management? As we said, it is the problem in the growth hormone sensitivity. Some may have growth hormone deficiency also. So growth hormone therapy is indicated. So, and what are the objectives of starting growth hormone therapy? To accelerate linear growth in early childhood, to achieve rapid catch-up growth, to maintain a normal growth in later childhood. And the ultimate objective of the treatment is to achieve the adult height within the normal target range for the family. What are the other benefits? Definitely there will be a benefit in the longitudinal growth. It will have a positive impact on the metabolic health, cardiovascular health, better body compositions, better neurodevelopmental outcomes, and bone mineral density. So it will not be only the height, it is the other aspects where the SGAs were being lacking. So GH will be helping them. So talking about the flow chart for the endocrine management, evaluation of the short child born SGA is recommended, and those under 2 years of age with the current length below 2.5 SD should be referred for evaluation. FDA approved GH therapy for SGA in 2003. The children are recognized and started. Those who are non-syndromic show a better response to GH therapy. Pre-treatment IGF-1 levels have a role in predicting responsiveness to GH. Whereas in those children receiving GH, IGF-1 monitoring is a tool for us to optimize the therapy. The treatment emergent adverse events are not very common in the population, and the safety has been proven in many studies time and again. So advantages of GH therapy for SGA children I have talked about. How do we monitor the children who are on GH therapy? A positive response is an increase in height SDs of plus 0.5 from the baseline in the first year of treatment. In those with a positive response to GH therapy, the long-term therapy is recommended. Though in India, for all practical purposes, because of the resource limitations, 2 to 3 years of therapy intermittently is being practiced and is still showing good results. Discontinuation of GH therapy in adolescents is recommended when the growth rate falls to less than 2 cm per year. What are the factors affecting? As we said, these children will need higher doses. Younger age at the start of the treatment will give us better outcomes. Higher height standard deviations and weight at the start of the treatment and higher mid-parental height SDs give us better results for the same children's. A little bit about the KICS study. The KICS study has shown that the children, SGA children, when started on growth hormone therapy, started on the appropriate dosing, they are definitely shown to have better results. In the first year of therapy, the growth hormone dose and age at start of the treatment is the major variable, which is defined, on which the growth ultimate results depend. In the second year, the response was best predicted by the parameters like age at the start of the treatment, which accounted for 34% of the variability. So I'll skip this slide. It's basically the conclusion is yes, that SGA children should be evaluated and treated appropriately. What are the gaps in the management? The gaps in the management of SGA are there's a less focus on the understanding of the SGAs among all of us. The absence of accurate anthropometric measures. Of late, I have been seeing children whose weight was normal, but when I insist on getting the day birth records, though the rarely I find, but whenever I find, the lengths are less. So apart from that, the regular monitoring on follow-ups is also important, and appropriate referrals to be done at the appropriate time. The limitation of the growth hormone, late initiation of the growth hormone therapy will give us poor results. So appropriate initiation is also important to get the appropriate result in SGA babies. Take home message is birth, weight, and length both are important. Regular monitoring of birth, weight, and length is critical, especially for the SGA babies. Plotting them on the appropriate charts is also important, so as to avoid overt catch-up or failure to catch up. Early and timely referral to a growth specialist is essential to initiate growth hormone therapy for an optimal outcome. Appropriate initiation of the growth hormone therapy instead of the wait and watch approach is of very much importance. So to summarize, early identification, early monitoring, early identification of those who were born SGAs, proper monitoring in high-risk clinics, and early referral when needed, and early treatment when found appropriate must be started. SGA with catch-up growth, monitor for puberty and adiposity. So even if the SGA has caught up for the growth, do not discharge him from the OPD. Monitor them 6 monthly and yearly for their SMRs and for BMIs. Thank you very much for the kind attention. Over to you, Richa ma'am.
Thank you, Dr. Kiran. That was a very detailed and the cases were very interesting. So definitely the important point is we have to see the cases at the right time and act at the right time. And they have a double-edged sword. Either they are short or they get obese. So we don't have to just work on nutrition and see the other parameters also. There are a few questions in the Q&A, but I will take the questions by the end of the session. So now we will go on to the next session by Dr. Divya. Dr. Divya is working as an associate professor and consultant pediatric endocrinologist at Sri Ramachandra Medical College, Chennai. She has done her MD pediatrics from Safdarjung and fellowship in pediatric endocrinology. She has ISPAD fellowship and ESP clinical fellowship to her credits. She has been an executive council member ISPE between 2021 and 2022. She will be discussing the case-based approach on Turner syndrome. So over to you, Divya.
Thank you, ma'am, for the kind introduction. I'll start sharing the screen. I believe my screen is visible.
Yeah, it's visible. Yeah.
So today, so my topic is to discuss about Turner syndrome. So I have may try to do some justification given the time limit of 15 to 20 minutes using a case-based approach. So before we move on to the case-based approach of Turner syndrome, so these are my disclaimers. So just a brief introduction about what is Turner syndrome for the audience. So Turner syndrome is a disorder which has a distinct clinical features because of some karyotype or chromosomal aberrations, because of a loss of X chromosome. So it could be a partial loss or a complete loss of the second X chromosome. So this happens specifically in a girl child who are like 46XX having the karyotype pattern, and the first X is remaining and the second X of the chromosome only is lost. So this leads to a trio of clinical features: infantilism, congenital webbed neck, and then short stature. So this was first described by a German endocrinologist, Dr. Otto Ulrich. He's as well as a pediatrician. And I think because of, there may be communication, or like, when they made the publication, it might have not reached the US at that time. So by 1938, a US endocrinologist, Henry Tanner, also described the same clinical feature with the infantile features, webbed neck, and the short stature. And, so they, in order to because they both have first described the same clinical features, so both their names are combined, and the syndrome has been named as Ulrich-Turner syndrome. But in short, specifically to say, like, we just briefed it as only Turner syndrome nowadays. Coming to the prevalence. So if you do a karyotyping in for all the fetuses, prenatal prevalence seems to be, somewhat higher. 1 in 3%. That is, every 3 child out of 100 fetuses we can identify. But what happens is that 99% of them undergo spontaneous abortion, and only 1% of these babies survive. And so the postnatal incidence prevalence actually drops down to 1 in 2000 to 1 in 2,500 live born female babies. So how to identify a Turner syndrome? It is basically you do a karyotype and they look for the, how much percentage of the X chromosome is available. So the most common thing is monosomy X, which is loss of 1 X chromosome. That is the most common structural defect you can see in a Turner syndrome. Followed by isochromosome X. What is isochromosome X? This is nothing but, as the picture shows, like, see, you can have a deletion of short arm of the X chromosome or a long arm of the X chromosome, namely represented as XP minus or XQ minus. What happens in isochromosome is that, whatever the deleted part, it gets, that gets absorbed, and the remaining part gets duplicated. So that, see here in this picture, this shows the isochromosome with a long arm of the X chromosome. So the long arm that has remained, the short arm is lost, but the long arm that is remaining, it undergoes duplication and it forms the isochromosome with the long arm of the X chromosome. And then the next common thing is the mosaic Turners. So what is mosaic Turners? You have a set of a normal karyotype or a little bit of different karyotype, but it is mixed along with the 45X. So you'll have monosomy in something, normal chromosome in the remaining percentage of the cells, as the picture depicts here. And the last is the ring chromosome. So what happens is the acrocentric parts of the chromosome, both top and bottom part of the X chromosome, only the tips get absorbed, and so that it forms a ring-like structure. So the significance of it I will be discussing in the next slide. See, the phenotype and genotype correlation of Turner syndrome is very important, because when you lose 1 X chromosome, so the specific set of genes are also lost. So for example, they'll have haploinsufficiency for the SHOX gene, ZFX, and USP9X. So these are some of the genes that are responsible for your height, skeletal abnormalities, gonadal failure, viability of the fetus. There are many things that are there. So if you have a child with the Turner syndrome, because of the chromosomal effect, loss of one X chromosome, that leads to your gonadal dysgenesis, and then you have misbalance. Even if you have a mosaic Turner, there is a gene dose misbalance. So that causes your haploinsufficiency of SHOX gene, loss of Y growth gene, which carries the important region for the lymphogenic areas. And so this leads to the soft tissue stigmata or the visceral stigmata, webbed neck, and etc. And also leads to the skeletal dysplasias like Maitland deformity or other skeletal deformities that are usually associated with Turner syndrome. Chromosomal imbalance and again SHOX gene haploinsufficiency leads to some specific, some non-specific developmental defects and as well as short stage. So a mosaic Turner who are having the rest of the chromosomes as a normal karyotype 46XX, they will have a milder phenotype. And if there is a Y chromosome 45X plus 46XY, so Y chromosome material, if it is present, they are at increased risk of gonadoblastoma. And if the presence of ring X chromosome is there, it leads to neurodevelopmental or intellectual disability. So clinical features, so as we all know that the child will have some syndromic features or the Turner stigmata, which is typically the short stature, short neck, webbing of neck, cubitus valgus, low hairline, edema of hands and feet, nail deformity, hyperconvexity of nails, gonadal dysgenicity, pubertal manifested as pubertal delay. So we all know all these features. The clinical features that are highlighted in red is actually some of the clinical features that we usually miss, because many times the child will come for some other palpitations, giddiness, syncopal attacks, chest pain or something like that, and then we found out that the child having a specific cardiac defect, and then we evaluate and find out to be Turner syndrome. So cardiac defects, kidney malformations, hearing impairment. So assessment of hearing, when you diagnose a child with Turner syndrome, always look for hearing assessment. It is very important. You can look at it like 50% of these children will have some form of hearing impairment. And also look for autoimmune hypothyroidism. These children are at increased risk of autoimmune disorders and also impaired glucose metabolism. They are at higher risk of getting a metabolic syndrome and as well as type 2 diabetes. So let us move on to case 1. So I saw this child at 10 years of age. The complaints was poor height gain and poor weight gain from 2 years of age. This is how our Turner syndrome girls present typically, especially in my practice. So birth history normal, she is good in studies. There is no history suggestive of hypothyroidism. Parents, father is short and paternal grandmother is also short. And as you can see, like 10-year-old, she is pre-pubertal, no goiter is there and her vitals are stable. She has some syndromic features, widely spaced nipples, pectus excavatum, and then webbing of neck. So you can make out here the webbing of neck, low hairline. The webbing can be made out much better here. And the short brachymetacarpia, so a short fourth metacarpal bone, and also the short toes of fourth and fifth toes. So she has some features that is suggestive of Turner stigmata. And anthropometry wise, if you compare, her height is less than the 3rd percentile, weight is also less than the 3rd percentile, and she is actually falling. If you project her current height according to the mid-parental height, her actual height is, projected height will be falling slightly less than the lowest percentile of mid-parental height, and she is pre-pubertal. So we have a child with a Turner stigmata, short stature, underweight, with probably query, father is short, whether it is a familial short stature, this and all is a but. We have to go ahead and investigate this child because the height is less than 3rd percentile, as Dr. Richa and Dr. Kiran has told in their previous talks. So any child that whose height is less than the 3rd percentile, always evaluate. So thinking that this child is having Turner syndrome, we progress with the investigations. So before I move on to the investigation findings, what I had in this child, let us discuss about, what is a natural growth in Turner syndrome, how to diagnose a Turner syndrome, how to manage a child. If you diagnose a child with Turner syndrome, how to manage and follow up the child. So clinical features. So this Turner syndrome has a spectrum of manifestations, starting from low birth weight, lymphedema, coarctation of aorta, feeding difficulties, failure to thrive during from birth to in the infancy period. The child can present like this, and in the childhood, the most common presentation is short stature, ear infections, middle ear infection, and then any intellectual disability, especially with spatial orientation, mathematical skill deterioration. So these are some of the common presentation during childhood. Adolescent, short stature, delayed puberty is the most common presentation. And in adulthood, like infertility, short stature, hypertension, hypothyroidism. So these are some of the common features. Now, coming to natural growth in Turner syndrome, say at birth, this is from the Act of Pediatrician Journal in 1988. So this is the prevalence of the birth weight and birth length for all the Turner syndrome babies. So the length and weight of Turner syndrome at birth is actually, as you can see, there is more dots cropping up below the less than the 10th percentile. This is the length and this is the weight. So, so the length and weight of the Turner syndrome child at birth is usually less than the 10th percentile. And if you have a child, it doesn't matter whether you have a child with mosaic or monosomy X karyotype, it doesn't make a difference because both have been underweight and as well as being born short during birth itself. So up to 3 years of age, as you can see in the chart that is comparing the CDC, the red one is actually the CDC charts and the bottom one with the blue lines are the Turner syndrome charts. So if you compare both up to 3 years of age, they are like within in the usual normal range. And at 3 to 10 years of age, the growth velocity starts falling. And after 10 years of age, what happens here is that there is no pubertal height spurt that is going to happen because of delayed puberty. There is no estrogen or because of gonadal dysgenesis. So the height spurt is not going to happen. And typically most of our children present with delayed puberty and a short stature. And when you evaluate, some of them turn out to be Turner syndrome. So the adult height, if you look at the adult height, the loss is like about 20 centimeters. So the loss is like 20 centimeters, and the average adult height of these children, if you leave these children untreated, are like 142. Now, some of you might feel like, 144 is not actually that bad. Okay. See, those who feel that way, let me ask you a question. Try driving a car or a two-wheeler with that height. Okay. So it is actually a disability. So if you look at it, nowadays, the turn is that like everybody is owning some or other forms of vehicle, like two-wheeler or a four-wheeler. And, if they are, it is like, form of physical disability if you are not able to, drive to a place, isn't it? So that is where the impairment is. So that is where early detection, early initiation of treatment is very important. If you treat adequately, then they have the opportunity to grow up to 164 centimeters. So detecting early and treating early is very important. So what causes short stature in Turner syndrome? We all know that these children are at higher risk of hormonal imbalances like hypothyroidism, delayed puberty. That could be a cause. Or there is short gene haploinsufficiency that can cause like skeletal dysplasias, dysregulated chondrocyte differentiation and maturation. And as I said, like in my one of the previous slides that I have discussed, there are some certain specific regions in the chromosome when with the monosomy X, those genes are lost, and that can lead to the growth failure. And point to be noted is that growth hormone does not correct the underlying skeletal defects. Now, how to diagnose Turner syndrome? We have to do a karyotyping. Make sure that at least 30 cells or 30 metaphases are looked into. And if you have a strong suspicion of mosaic syndrome, you can get a fluorescent in situ hybridization, which will usually look into 100 cells. And that will help you in diagnosing a mosaic turn. So the indication are any short girl child, you have to do a karyotyping, no compromise in that. Delayed puberty and you suspect some Turner stigmata, do it. Any characteristic phenotype, as I mentioned in this this particular case, cardiac anomaly, skeletal deformity, Maitland deformity. We'll see what is Maitland deformity is. So this is the distal radio-ulnar joint subluxation, causing a typical dorsal flexion of the ulnar bone and the movement restriction of the wrist joint. So this is Maitland deformity. And any two of the following, if it is present, also one should have a strong suspicion of Turner syndrome, like a renal anomaly, Maitland deformity of the wrist, neuropsychological problems, multiple pigmented nevi, hyperconvexity of nails, hearing impairment with the short stature. So any two of these features, if also present, one should strongly suspect Turner syndrome and do a karyotype. So now moving on to investigations in our child. So like any short child, as mentioned by Dr. Rischa, you have to rule out some systemic screening to rule out any systemic illnesses or chronic illnesses. So this child, all the parameters, including hypothyroidism that we have done, are like not suggestive of any illnesses. But the point I wanted to note down here is that look at the FSH-LH, because this child is 10-year-old. We have to do an FSH-LH and estradiol, especially with the Turner stigmata that the child is having. We need to do that. And if you look at it, this is the typical presentation, like, elevated FSH and elevated LH levels, elevated gonadotropins with the, undetectable levels of sex steroids. So hypergonadotropic hypogonadism, that's what is commonly seen in Turner syndrome. So, and then we have done the rest of the remaining investigations, like bone age, which is 8.5 years. This child is 10-year-old, not very significantly delayed. Echocardiogram was normal. Ultrasound is showing a infantile uterus and ovary, and the KUB is normal. Now, we asked for a 30 cells karyotype, and this has shown all in all 30 cells, it is 45X. And given the Turner syndrome features in this child, I expected only monosomy X, so I did not do a FISH in this child. So this is how we prove a diagnosis of Turner syndrome. Generally, it takes like 3 weeks to 4 weeks time for the karyotyping to come. How to manage? Now we have diagnosed this child to have Turner syndrome. So how to manage? The one point is that this child is short and the child's bone age is 8.5 years only. So this child is left with a limited period of time that she can grow. So it is better to give growth hormone in this child. And for optimal growth in a Turner syndrome, you have to give growth hormone. The earlier you initiate it, it gives the best result. Even for children who have started at a later age group, like 14 years, 15 years, like that, you can try oxandrolone if it is available. And estrogen therapy should be started by around 11 to 12 years of age. Preferably, if you are starting a growth hormone, at least 3 to 4 years after growth hormone therapy, you start with estrogens. And also you have to regularly screen for other associated diseases like hypothyroidism, celiac disease, etc. Now, so the majority of the dosing guidelines, follow-up guidelines, I have taken it from the 2016 Cincinnati, Turner syndrome meeting. This is easily available for download from the internet. So what is their recommendation regarding growth hormone therapy in Turner syndrome is that you have to initiate growth hormone therapy as early as possible, at least by 4 to 6 years of age, and preferably before 12 to 13 years of age, especially in a short child whose height velocity is below the 50th percentile for 6 months in the absence of other causes, short parents, signs of puberty at presentation. You need to start as early as possible after the diagnosis. Initiation dose is somewhere between 45 to 50 micrograms per kg per day. And the maximum dose you can go up to 68 micrograms per kg per day if you feel the child has an compromised adult height potential. So if you start by 7 years of age, the adult height improves by 12 centimeter and only 5 centimeter after 12 years of age. So how to monitor growth hormone therapy? You need to do an IGF-1 at baseline and as well as annually. The goal is to keep IGF-1 levels less than 2 standard deviation. Reduce the growth hormone dose if IGF-1 levels are more than 3 standard deviation. try to maintain it less than 2 standard deviation. It is good. And for an IGF-1, that is between plus 2 standard deviation and plus 3 standard deviation. Use your clinical judgment. If you feel this dose is required for the child to grow properly, you can continue with the same dose, or you can decrease it a bit. So factors predicting growth hormone response, good response to growth hormone therapy, if they are relatively tall at initiation of therapy, not the height difference or the height compromisation is not that severe, or the parents are quite tall, the younger age at the initiation of therapy, longer period of growth hormone therapy before induction of puberty, longer the duration of growth hormone therapy and higher the dose of growth hormone, or certain factors that says the child will respond well to growth hormone therapy. Oxandrolone therapy, see, at least in Chennai or in Tamil Nadu, it is not available. I'm not sure about Jaipur and Delhi, whether oxandrolone is available there. So I have no experience in using oxandrolone therapy because it's not available here in Tamil Nadu. So it is used either alone or in combination with growth hormone. Especially you diagnose a child late, like 10 years and above. Routine use is usually not recommended. It has a how does it act? It acts directly at the level of growth plate, increasing the production of IGF-1. So it is usually reserved for children who have a delayed initiation and poor response to growth hormone therapy. Dose is like 0.03 milligram per kg per day. It has adverse effects dose dependent virilization and as well as hepatotoxicity. And also one had to screen for other associated disorders like celiac disease, hypothyroidism, type 1 or type 2 diabetes mellitus, vision, ocular disorders, otitis media, hearing loss, hypertension, neurodevelopmental assessment, especially spatial orientation and mathematical skills, bone health, for osteoporosis. And if the child has a Y chromosome material, serially monitor with ultrasound for the risk of gonadoblastoma, or you can plan a gonadectomy. So follow up. So we do screening at diagnosis. So apart from anthropometry, we do a thyroid profile, lipid profile, LFT, HbA1c, fasting blood sugar, vitamin D, celiac screen, renal ultrasound. See, not to forget audiometry, optal evaluation, dental evaluation, congenital hip dysplasia, skin examination, bone mineral density assessments. So all these are done at the diagnosis and should be done at diagnosis. And depending on, if the child has everything in the normal range, then maybe, at every clinical visit, measure height and weight. And annually, you can do a thyroid profile. If the child is more than 10 years old, you can monitor for glycemic abnormalities. And every 2 or 3 years once, you can do the rest of the assessment of hearing, celiac disease observation, and then your vitamin D levels all can be done every 2 or 3 years once. So I'm not going to talk about adults here and how to follow them up. So this child in the management and the follow-up. So we have started with actually a lower dose of growth hormone in this child. Because the child was very poor and logistic issues, the child is receiving growth hormone from our Chief Minister Fund. So I have to start with a lower dose possible. And, the child is currently 14 years old and the height is 135 centimeters. So the total growth velocity is like 22 centimeters in 44 months. So I have divided and kept here, 6.5 centimeters in the first 12 months, second year again 6.5 centimeters, third year very much low, 4.2 centimeters. And in the past 8 months, the child has grown like 4.8 centimeters. The impact is actually due to why the poor growth velocity in the second and the third year is actually due to COVID pandemic, poor availability of growth hormones, because most of the health resources are utilized for managing COVID patients. So that is major. And this again shows the importance of compliance to the growth hormone therapy. Every day, the child has to take the growth hormone at the specific dose before going to bed, somewhere about 7 to 8 p.m. in the night. So currently, the child in the past 8 months, the child is receiving a growth hormone dose of 0.41 milligram per kg per week, along with a lower dose of estradiol. She is even now having, no pubertal development because the starting dose of estradiol is very less, 1/4 of Proguanil only I have started. So because of the very smallest dose, the child, even though child is 14-year-old, she's still pubertal, and the bone age is like 11 years. And I'm just trying to buy more time here before increasing further estrogen doses, at least for another 6 months or so, and then we will be increasing the estrogen dose here. So IGF-1 and again TTG we could not do because of logistic issues. So moving on to case 2, this is a 2-year-old female child, very interesting patient, actually antenatally diagnosed with Turner syndrome because of mild aortic valve stenosis observed in the antenatal scans. So we have done a CVS and amniocentesis. And in the amniocentesis, the child was karyotypes observed to be, mosaic Turner actually. So the birth history, as you can see, like, majority of these children are born underweight, 2 kg. And the issue with which the child came to me is poor height and weight gain. And the child was managed, only symptomatic management is given, and the child is not on any medications for the aortic stenosis. There is no goiter, vital stable, and if the audiences can make out, like, there is webbing of neck, and there is this lymphedema surrounding the neck that you can observe in this picture. So this child is again, short. The height is very much way below the, way below for the corresponding age, and the weight is also less. Height circumference is normal. So I don't have to evaluate this child further because the child, already diagnosed with the Turner syndrome, and the postnatal karyotyping is also done to confirm it. So there is no need to diagnose Turner syndrome now. Now, the key points to discuss in this patient is, how an antenatal diagnosis of Turner syndrome is made, and whether, initiation of growth hormone in Turner syndrome, how early we can initiate. And also this child has a cardiac malformation. So what are the cardiac care should be done in a Turner syndrome child? So prenatal, if the child has any of these features and in the antenatal scan, like increased nuchal translucency, cystic fibromas, coarctation of aorta, or left-sided cardiac anomalies, renal anomalies, especially the heart-shaped kidney or an atrophied kidneys, brachycephaly, polyhydramnios, oligohydramnios, and growth retardation, or even an abnormal triple or quadruple metal serum staining, you do a CVS or amniocentesis, and these are actually screening tests and not diagnostic. Even if you do a the confirmatory thing is that you have to do either an amniocentesis or a chorionic villi sampling. And even again, even if you prove that this child has a monosomy X by your amniocentesis or a CVS, you have to do a mandatory postnatal karyotype using 30 cells or 30 metaphases and confirm the diagnosis of Turner syndrome postnatally. So how early one can initiate growth hormone? So you can initiate as early as possible, as represented in this study from US, toddler Turner syndrome study conducted between 1999 to 2003 among children with the Turner syndrome aged between 9 months to 4 years of age. This graph only speaks everything here. Okay, so if you look at it, the initial growth of both these children is like, comparable, but when the child who were started on growth hormone, you observe the difference here. The growth is so much better, minus 0.34 standard deviation only. So the growth is so much better compared to untreated children. So and this height gain actually, somewhere between 1.6 plus or minus 0.6 standard deviation, and this correlated, the height gain correlated strongly with the difference between with the mid-parental height SDA subjects, height SDA at the time of diagnosis, and the initial treatment response data. And also, early versus late growth hormone therapy, because early in this study, again, it's a German study, and early means those who were started on growth hormone less than 12 years of age, compared to late initiation of growth hormone more than 12 years of age. Okay, so if you look at it, the adult height in the early GH group is like, those who had roughly about 7.5 years of growth hormone therapy gained like about 150 to 153 centimeters. Versus in the late group, there is 2 years short, of growth hormone therapy. So only 5 years these children have received growth hormone therapy, but their height is also more or less similar, 151, 152 centimeters. So the difference is not very significant when it comes to the final adult height. Whereas in the initial few years of treatment, they are all, those who are early treated early very well, they are growing at, much higher rate compared to the late initiation group. Why this adult height difference is not coming really significant is that it is the chronological age at which the pubertal induction was started. So the late group, more than 12 years age group children, they have been induced to puberty at a later age, like, about 15 years of age. So probably that could be the reason why the adult height gain is not coming very significant. So this child has a cardiac defect. So how to, approach the cardiac care? So bicuspid aortic valve is more common, and PAPVR is the next commonest lesion. Biaptation of aorta is the third commonest lesion, and they can also have rhythm abnormalities like a prolonged QT interval, and many times it could be silent. And this is why it causes the most common cause of sudden death in Turner syndrome, especially aortic dissection. And the risk factor is, you need to do a cardiac MRI. Nowadays, that is what is most preferred compared to an echo. Of course, cost is there. But if possible, always do a cardiac MRI, and the aortic root dilatation measurement can be measured. And if it is more than 4.1 centimeters, these people are at a higher risk of aortic dissection. And this is easily preventable, predictable, and you have a separate guidelines that is available for managing this aortic dissection. So the last case is a 16-year-old female child. I'm sure like both Dr. Richa and Dr. Kiran both agree that this is how in our practice, a Turner syndrome child commonly presents. Delayed puberty, not attained menarche is the major complaint. 16-year-old girl child or a 15-year-old girl child, let's say. And typically they'll have a normal birth history, developmental history, nothing suggestive of hypothyroidism. This particular child had a short parents, very much short parents. So they are not really, wondering about why their child is not growing them. So because they themselves are short. So that's how I am also short. My child also will remain short, that kind of an attitude. And if you look at it, the child doesn't have a goiter. The child has multiple pigmented nevi. I hope these small dots that are visible to the audiences in the neck and as well as in the chest region, and also clinodactyly, curvature of the little finger. And she is still 16-year-old girl, still pre-pubertal. Her vitals are stable. So we have a child with a short stature, delayed puberty. I have made a diagnosis of Turner syndrome because I can make some subtle Turner syndrome features in this child, basically the clinodactyly and the multiple pigmented nevi. Sometimes the clinical manifestation will be very silent. The child will not even have any manifestation of Turner syndrome. It is very important, again, like the dictum is any short child presenting with any short girl child, always do a karyotype. It is a very must investigations. So this child had a mosaicism of Turner syndrome. So 40% of her cells have 45X and 60% of her cells has isochromosome of long arm of X chromosome. So this is a mosaic Turner patient. Now, key discussion in this case is that, understanding puberty in Turner syndrome, role of HRT, and how to induce puberty in a Turner syndrome. So puberty in Turner syndrome, because of ovarian insufficiency, there is no estrogen and progesterone, there is no secondary sexual characteristics. So approximately 70% of these patients will not even have a telarchy. And hardly 5 to 10% of children go through some amount of spontaneous puberty, and less than 1% of these children have even have a menarche, but that won't progress to regular cycles, and most of them will not have a menarche. Adrenarche, that is the appearance of pubic hair and the underarm hairs and the sweat smell, etc., usually occur at a normal age. That is because of normal adrenal function, but this does not progress to puberty. Coming to role of HRT, it is very important because estrogen contributes to growth at lower doses, and also the child has to have appropriate secondary sexual characteristics at appropriate age, and also attaining peak bone mass, and also to normalize the uterine growth. So how to begin or induce puberty in Turner syndrome? Begin at 11 to 12 years of age. If the gonadotropin, FSH, LH, and estradiol levels appear normal for the age, observe for spontaneous puberty. If not, you initiate with lower doses of estrogen. Why lower doses of estrogen? We have to preserve the adult height potential. You can continue with the growth hormone till the height velocity falls less than 2.5 centimeters per year, and the epiphyses are not fused. Till then, you can continue with growth hormone. Every 6 months, you increase the dose of estrogen to a period of about 2 to 3 years period, and add progesterone once the breakthrough bleeding occurs or after 2 years of treatment. We usually tend to use medroxyprogesterone acetate, 10 mg OD for 7 to 10 days. So why we have to start progesterone a little bit later, after 2 years of treatment? This is because we have to allow or give time for the endometrium and the uterus to grow further, and also to achieve full breast development. So the preferred preparations nowadays, I think most of our pediatric endocrinology society is using only the estrogen valerate at an initiation dose of 0.25 mg per day, and then you can go up to 4 mg per day. That's the adult dose. And transdermal estrogen, again available, not very costly. You can initiate at a dose of 3 to 7 micrograms per day and you can slowly increase up to 100 micrograms per day of adult dose. So now the typical question is, whether a 16-year-old girl, short, whether we can start growth hormone therapy also, because right now we have to initiate estrogen in this child because she is not even having any secondary sexual characteristic. So whether we can also initiate growth hormone therapy. So what happens here is that, this black rhomboid diamond indicates the early initiation of estrogen compared to a late initiation of estrogen. What is the late and early is that those who were initiated with estrogen less than 12 years is the early group, more than 14 years is the late group. So if you have a look at it, the early initiation of estrogen group, the black diamond group, so that group has grown much better compared to the late initiation group. So difference is like 3.5 centimeters more, and the total gain is like 5.9 centimeters. The conclusion is that estradiol doesn't interfere with the growth hormone induced growth enhancement, and also it stimulated the growth without any deleterious effect on the height potential, and also it promotes the growth further. Now, because these children are having gonadal dysgenesis from the beginning, from birth, they are estrogen deprived from birth. So if we initiate a low dose of estrogen from childhood, will it be better or bad? Let us have a look at it. So this study published in NEJM says that, as the table mentioned and also in the graph that shows, compared to placebo or estrogen alone group, the growth hormone alone group performed better. Even much better is the combined treatment group, growth hormone plus estradiol, the growth gain is much better. However, there is some ethical issue of initiating sex steroid in a prepubertal child, and how much dose we have to give, that and all, some guidelines are yet to come. Till then, I think it is better not to use estrogen in childhood, at least. So fertility preservation, though, I mean, we don't see as pediatric endocrinologists. I think I can just tell, like, there are many techniques of ovarian tissue cryopreservation, oocyte cryopreservation are available in India. And there are chances of fertility with the use of artificial reproduction techniques is possible even in Turner syndrome child. But however, one has to remember that, there is a higher risk of medical complications when they undergo these procedures because of the associated comorbidities in these children. So the key messages from my presentation that I wanted to highlight is, suspect Turner syndrome in all short girls and in girls presenting with delayed puberty. Always ask for a 30-cell karyotype, and in short stature child, early diagnosis and early initiation of growth hormone has a better prognosis. Age at initiation and dose of growth hormone are critical factors to predict good growth hormone response. And puberty, always initiate with the lowest estradiol dose possible and start at like 11 to 12 years of age if the FSH levels are very high. And continue with growth hormone as well, even if you start on estradiol for a promotion of growth. Multidisciplinary management. So sending them to an endocrinologist or a physician alone is not enough. We have to do a multidisciplinary management. I'm going to show in the next slide what is that. And for comprehensive care, the guidelines are available, 2016 Cincinnati guidelines, and it is available freely to download. So this is what the multidisciplinary management I have been talking about. Not only it is the puberty issue, the fertility issue, it is a comprehensive care. A comprehensive care means, cardiac care, addressing the intellectual disability, addressing the hearing impairment. So, and also, coming in together, like, the pediatrician may be different, pediatric endocrinology will be different, another person. So instead of like, moving to multiple places, if possible, like we all have to at least once a year, manage these patients as a multidisciplinary team so as to benefit these patients. So that is one area I believe, like in Turner syndrome, we are all lacking on. With that, I'll finish my presentation. Thank you all for your patient listening. I'll stop sharing.
Thank you, Dr. Divya. That was a very nice presentation with a very detailed discussion of the cases. And definitely we are maybe missing out certain cases, not in the timely diagnosing them. And the very important message is a timely diagnosis and suspecting it in any girl child who is coming up with short stature, and there is, even if they don't have any Turner stigmata, we should have a very high index of suspicion. Yes. So there are a few questions in the question answer. I will just take up the questions. So in the question, for Turners, as you have discussed it in few cases, that if we have a child who has been diagnosed prenatally, so what do you suggest, that at what age should we start the growth hormone treatment? Practically, what? Okay. Because once they know a Turner syndrome, they Google it, growth hormone, the parents start asking at 1 year also. Shall we start it at that time, or shall we wait for 4 to 5 years? What do you say, and what should be the best approach? So
the early initiation is always better. I have shown in one of my slides the Turner's toddler study. So they have initiated even at the age of like starting from 9 months of age. So, and it is, it is better to use it because these children are going to have these hormonal instability. Why to wait till they falter in their growth? And, so you mean we will be starting at 9 months and maybe continuing till 12, 13 years? If we suppose that there is no cost constraints and we can give it freely. Yes. So we should be the child, till the height velocity drops to less than 2 centimeters. 2.5 centimeters per year. It should be continued actually. It should be continued. So that is the ideal approach that we should be following it for such tips. So when we give this growth hormone therapy, are there other side effects as compared to the normal side effects in what we see in a non-Turner child? Are there additional certain side effects that we observe in such kids? in my personal experience, I haven't seen any other side effects of growth hormone in Turner syndrome.
Because we are
but-
giving it a bit higher dose also as
Yes.
compared to.
But so far in my practice, I haven't seen or observed a side effect, touch wood. But these children, because, they are already at a risk of, abnormal glucose tolerance, one need to keep a watch of blood sugar and A1C at least annually. And if if the impaired glucose tolerance has started occurring, then one need to be much more careful with the growth hormone dosing and all. Another thing is because of the bony defects, some of these children can have, and if they gain so much of weight, if they are obese as well, they can have what is called as the slipped capital femoral epiphysis. And then scoliosis, again, is a most common defect that we see in Turner syndrome children. So these are, even though growth hormone doesn't promote or cause these side effects, but one have to be really careful. If they, especially when they complain so much of hip pain or more curvature of the spine, etc., one need to be careful in adjusting the dose or a partial withdrawal and then reinitiation or something like that.
Yeah. So, but as such in literature, what we see there is they don't say that the chances of diabetes are increased when we are using growth hormone therapy as such but definitely as with every child of Turner's, we have to be more cautious. As you also discussed the comorbidities associated with Turner's. So how frequently we should be monitoring these comorbidities that we see in the Turner's, like thyroid or diabetes for a routine child?
Yes, ma'am. So at diagnosis, it is compulsory. You have to rule out all other associated like cardiac, renal, hearing, optal, LFT, including LFT, autoimmune hepatitis again is more prevalent in Turner syndrome. So it's better to do a thorough evaluation at diagnosis. And then if the child is all right at diagnosis and you don't suspect any other complication, maybe annually you can do a lipid profile and TFT. Rest of the things like your hearing assessment, celiac disease screen, or your ophthalmic assessment, bone mineral density, vitamin D, all those things you can do. If you want to cut down on the cost, maybe 2 to 3 year once. But definitely a lipid profile and a TFT is a must annually. BP measurement and along with your anthropometry is a must at every visit. If possible, I would say all 4 limbs BP is a must.
So we routinely also advise getting an echo for these kids because they may have, as you mentioned also, because as the main dictum is that monitoring and obviously multidisciplinary approach. These kids which require multidisciplinary approach, and if they can meet once in a while to all it, but we still don't have that. There are certain support groups also for such Turner syndromes, and they join it, and it is more useful to them. Yeah, and definitely it has been seen that if we see a child who has received a growth hormone and not received, it has been seen there's a difference of how much difference in the height does it affects if we are treated child and a non-treated child of a Turner's.
So they generally lose about 20 centimeters, and the average height in an untreated child is about 144-45 centimeters. Which is very less, that's what I said in my talk, the major disability is with driving. So if you are not 148 centimeters at least, you won't be able to reach the brake pedal of your car, or you won't be able to reach the ground if you are driving a two-wheeler. So that's where the disability is. And I think with the rate at which India is progressing, I think I don't know, so many families will start having some form of vehicle, and that's going to be a major impairment. So
definitely already these kids have so many issues, and if we have a treatment for certain thing, why not at least offer to them?
Yes, and we can save if you are treat early, you can 20 centimeters, you can improve on it.
20 centimeters is a big number.
Yeah, if you start early.
So there are few questions regarding SGA also. Dr. Kiran, you have explained in detail about, but this just a recapitulation of what you have already discussed. How long the treatment needs to be given, matlab, if for the appropriate benefit of the child?
So the literature is suggesting once we have started a SGA child, suppose you have started at like 5-6 years, then it's better again to continue till the attainment of the final adult height, or till the growth velocity is less than 2 centimeters per year, and or the ellipses are fused. But what is practically coming in, and as per as the Indian literature is suggesting that because our children are not taking it for such a long time, so what is actually happening is that they are taking for 2 to 3 years, and then intermittently again they are taking it for 2 to 3 years. The results are comparable.
Yeah. So basically, important is at least initiating, and if there is, if we assume that we have a child who doesn't have any cost constraints, so we can give it till as long as possible. And if there is at least intermittent therapy, will definitely benefit for such children. And as we have seen, as we have discussed also, there are two major spectrums in SGA. One, we have a short child who will be short, underweight. And on the other extreme, we have a child with metabolic syndrome and other hyperinsulinemia, PCOS, and other issues, hypertension. So, and as we all know that one of the side effects of growth hormone therapy is blood sugar gets increased. So, what does the growth hormone therapy affects the chances of having diabetes in a child with when we are giving growth hormone therapy to a SGA child?
Actually, the growth hormone has shown beneficial effects in regard to the metabolic complications which are already there in an SGA child. So it is not like that an SGA child who's already at increased risk, the GH will further potentiate the possibility of having diabetes. In my understanding, it is not like that.
Basically, it is safer. It is a safer drug, and it's not going to land up any problems, as it has been suggested that they might have a relative growth hormone deficiency, or IGF is not working in it. So when we increase the level, but it doesn't cause any metabolic side effects. That is the main take-home message, and we don't have to worry about it. If it is an SGA child, we don't give a growth hormone. It's going to be beneficial only, and not with associated side effects. So according to the guidelines, if we see, age of starting is because now when we are creating so much awareness, we are seeing that start seeing the kids from 2 years also. There is no catch up. So what you in your practice, what do you follow? At what age you start to initiate the growth hormone?
Well, though as the guidelines are saying for a term SGA, we should start after 2 years, but practically many a times what we are seeing that these children are also having malnourishment in terms of weight. So first of all, whenever the child is coming to me, I would first work on the calories, appropriate calories and nutrition. And like maybe for 6 months or a year, we will work on the weight aspect of the child. And then gradually start. Mostly a term SGA, 4.5, 5 years, we have started GH therapy. And although for preterm SGAs, yes, we wait a little more, maybe around like 6 years of age. Though the guidelines are like saying 4 years for them, we are like taking this plus minus 2 years, especially if the graph is going in the positive direction and the growth velocity is appropriate.
Yeah, actually, these guidelines have been made from Western literature. So ours, we take a nutritional aspects also. So that's why we keep maximum by 5 years. We think that we should be starting. And the response of the growth hormone therapy, how is it different in an SGA child as we compare it with the growth hormone deficient child?
The doses again in SGA are higher than those in the GHTs. Yes, but the results are good. If in a child non-syndromic SGA, the results are definitely very good. In a child who like this RSS child, the results are still fair. And I would like to share my experience that this RSS child actually benefited in aspects of the cognition and behavioral issues. though she came to me at like quite a late age, but the improvement in the other aspects apart from the height is also very phenomenal. So the benefits are there, and they're better in non-syndromic SGS than the syndromic SGS.
But if we compare the response of the growth hormone, if in a growth hormone deficient child as compared to SGA, we can see that the response to therapy in a growth hormone deficient child is far better, because they grow suddenly and they show a better spurt. So it's better to we always explain to our parents that we are not like in a GHT child, the kids grow up to about 1 centimeter per month and maybe up to 10 to 12 centimeter in a year. If we compare it with an SGA child, they don't have such a drastic response because the underlying pathology is different. So definitely we see this type of differences.
Definitely.
So the similar, there's one question which suggests that do we require to go for an MRI when we are in an SGA child before starting the growth hormone therapy?
Well, the guidelines are not suggesting that, but it has been seen, and the literature is suggesting that some of the SGAs may be growth hormone deficient. And like if a growth hormone deficient child is showing an abnormality on an MRI, then the child does not need that growth hormone stimulation testing, and the doses they will respond to the lower doses. So it depends basically on the clinical clues. So it's not like that every SGA child is being subjected to MRI.
Like we are not, Dr. Divya, you can also, we are not going for a GH stimulation test in SGA. No? According to guidelines, we are not going for a.
Not right.
And IGF is also normal in most of them.
Yes.
So what do you suggest? Shall we go for is an MRI routinely indicated?
No, in my see, MRI, I think it is better to do because it will give you some critical clues regarding the pituitary hypothalamic region, and also many cyst mass or anything like that. It is, I mean, in my this thing, like I generally don't do a growth hormone stimulation test. I would rather prefer doing an MRI and then initiate growth hormone in these children. Like many children in at least like about 10 to 20% of these children, I have observed, like, they have some issues in the HP axis that I have observed so far. Like, especially the stalk interruption, small anterior pituitary, all these are clues, ectopic posterior pituitary location. So these are some clues that says that the child also has a growth hormone issue as well. Like probably.
And in case of Turner, sorry.
Maybe IGF-1 levels will be helping us to suggesting for the possibility of GHT.
Yeah.
If SGA has lower IGF-1 levels, then yes, we may consider the possibility of GHT, and then I would go for an MRI thinking the possibility of GHT. If the IGF-1 levels are on higher side, as it is generally seen in those who are actually SGAs, I generally don't do MRI.
Actually, guidelines also don't recommend doing a routine MRI for this, but it's basically, it depends upon the clinician what he thinks about it. Okay, I can't see any further questions. Just closing remarks from Dr. Divya and Dr. Kiran, and then we can.
Okay, early diagnosis, early initiation of growth hormone therapy. Always, catch up early. At least or to all the pediatricians or the general physicians that are listening to our talk, at least plot the child's growth in a growth chart at the first visit itself, and identify these children early. And refer to appropriately to a pediatric endocrinologist so that we can evaluate and then treat these children so that they can have a good adult height when they grow up, and as well as we can monitor the metabolic parameters and the other comprehensive care as a team we all can collaborate and we can improve the Turner syndrome care in India. That is from my end.
Thank you. Thank you, Dr. Divya. Dr. Kiran, your closing remarks.
Yeah, we have done phenomenal work in regard to reducing the morbidity in low birth weight preterm babies. Now it's the high time that we improve their life by reducing the morbidities, taking care of SJ babies, early identification and early treatment. Thank you.
Thank you, Dr. Kiran. Thank you, Dr. Divya.
Thank you.
It was the key message is early identification and early treatment. And thank you, Pfizer team. Over to Mayank.
Thank you, ma'am. On behalf of Pfizer, I am immensely thankful to all the three eminent speakers for interactive and insightful discussion with clinical experiences, definitely which will create more impact in day-to-day treatment of endocrine cases. Really, I enjoyed entire session. I was gone my previous first or second class teaching time. You nicely explained. And I also extend thanks to all the participants for your presence and managed time from your busy schedules. Thank you, everyone. And thank you to all three speakers.
Thank you,
Good night.
Mike and Velmurugan and Pfizer team.
Thank you, ma'am. Thank you, ma'am.
Thank you.
Thank you.
Good night.
Bye. Good
Bye,
night.
Dr. Richa. Bye, Kiran.
Bye.